We are in our last lesson, that is chapter 84 from our guidance, that is the applied physiology of renal system. So first we need to see some glossary terms and understand how they are associated with the topic today. So first one is anuria. So anuria, in the name itself you can see anuria means without any urine formation. So cessation and passage of urine mainly due to failure of kidney function, that is a passage of urine less than 500 ml per day. So actually here the problem may be any kidney dysfunction, or whenever the urine which is passed per day is less than 50 ml, then it is called anuria. The next, pressure diuresis. So in the name itself you can see because of high pressure there is higher amount of urine forming. So increase urine passage when arterial pressure increases. So because of arterial pressure has increased, it will lead to more pressure. So because of this pressure the urine will start getting out. So diuresis and mechanism. So let us see how these are associated. So diuretics are the one which we give mainly to increase the urine volume output, right, and increase the urinary excretion of solutes, especially like sodium and chloride. So why we are targeting mainly on the sodium and chloride solutes? Diuresis means a large amount of urine volume, right? So sodium and chloride are the solutes, whenever they move out from the body, even water follows it. So that is the main reason why we target them. So we stop the reabsorption of this sodium and chloride. So because of this, even the water will stop reabsorbing, so that most of it is lost in the urine. So many diuretics mainly reduce the sodium reabsorption, so that it's main target, so that water also follows the sodium. And the most common clinical use of diuretics is to reduce extracellular fluid volume in edema. So in edema we have a lot of extracellular fluid volume. So in these cases we can use diuretics, and also in hypertensive cases, because hypertension is nothing but whenever our blood volume is very high, or when the blood pressure is very high, right? So when the blood pressure is very high, if we try to remove this excess water from the urine, so that we can maintain the blood pressure. So in edema or in hypertension we can use diuretics. Now let us see what is osmotic diuresis. So it's actually increase in osmotic pressure in the tubules will lead to decrease in water reabsorption. So we have some osmotic substances are nothing but our solutes, mainly solute salts like sodium, chlorine, right? So if there are more in our renal tubules, even the water follows them, so that it will lead to diuresis. So for example, we have excess glucose which remains as an osmotic diuretic in the tubule. So this is leading to water in urine. It is seen mainly in diabetes mellitus. So in diabetes mellitus actually there is lot of glucose in the body, so that glucose transport reach transport maximum, so that no more glucose transporters are present, so that the glucose will present in the tubule. So because of this, water also follows it. So here polyuria will take place, especially in diabetes mellitus. So it is also balanced by polydyspea. Polydyspea means drinking more water. So a polyuria, you want to balance it, then you need to drink more water, of course, because lot of is going out from the body. So we need to drink now, so that to prevent the dehydration. So higher intake of water, and thereby increasing the extracellular fluid osmolality due to dehydration. This will also activate the thirst, because you can see the extracellular fluid osmolality will increase when the fluid is lost from the body, because all the solutes are now concentrated, so the osmolality of the extracellular fluid increases mainly in dehydration condition. So this will also activate the thirst system. So of course, if the system is activated, you are by yourself will drink more water. So remember, osmotic diuresis is nothing but some solute actively participant solute is present in the tubule. So because of this, even water reabsorption is also decreased. So next we'll see loop diuretics. So what are loop diuretics? In the name itself you can see loop means mainly it is acting on loop of Henle. So on loop of Henle we use this diuretics. Why we are using this? This mainly decrease the active sodium, chlorine, potassium reabsorption. We already discussed in our previous videos that in renal loop of Henle, actually we have sodium, potassium and 2 chlorine transporters. So actually they take up the sodium, chlorine and 2 chlorine and 1 potassium. So if we stop this loop diuretics, what they do, they stop this mechanism, so that they are nothing but they are like acting now as osmotic diuresis. So this will also lead to diuresis. Not only diuresis, even the sodium, chlorine, potassium, all this also will be losing in our urine. So especially it is taking place in the thick ascending loop of Henle. So examples are like furosemide, ethacrylic acid, bumetanide. So these are the powerful diuretics which mainly prevent this, so that lot of along with urine you will also see the sodium, potassium, chlorine, etc. And here, because of this, as more urine is going out, even there is decrease in osmolarity of our medullary interstitium, because in a previous normal case, whenever this loop of Henle take up all these solutes, it will lead to higher higher osmolarity in the medullary interstitium. So because of now this process, as everything is going on urine, even the osmolarity of the medullary interstitium drops. So loop diuretics mainly impair the kidney's ability to either concentrate or dilute urine. Of course, because as the medullary interstitium is gone already, and even now the lot of urine is going on, so even this ability to concentrate and dilute urine is also lost. So therefore 20 to 30% of glomerular filtrate which is delivered to urine, so urine output is 25 times of normal. So what they mean is, normally only 20 to 30% of glomerular filtrate is only delivered to urine, because urine output is also normal, because this thick part of ascending loop of Henle only it participates with this 20 to 30% of filtrate only, so like there is not that much loss. But by using this, especially loop diuretics, there is like almost lot of loss of the solutes and also water. But if you use another diuretics like thiazide diuretics, which mainly act on your distal convoluted tubule, but in distal convoluted tubule we have only the sodium chloride reabsorption process, because here only small part, only 10% or so is activated. So thiazide diuretics, of course they will also lead to diuresis, but not that much greater when compared with the loop diuretics. So here let us see, they mainly inhibit the sodium chloride reabsorption, especially in the early part of distal convoluted tubule. So examples are like chlorothiazide, maximum 5 to 10% of glomerular filtrate to pass into urine. The same amount of sodium is reabsorbed by the DCT. That is like how much amount of sodium the DCT can reabsorb, that much amount will directly just go into the urine, because it's like just only 5 to 10%. So now let us see what is carbonic anhydrase inhibitors block. So already we have seen before, like in many reactions, that water plus carbon dioxide in the presence of carbonic anhydrase, they convert into carbonic acid, and this carbonic acid in turn converts into hydrogen ion and bicarbonate. This process we are seeing it many times, right? So this carbonic anhydrase mainly it these are inhibitors which mainly block the sodium bicarbonate reabsorption in the proximal convoluted tubule. So in proximal convoluted tubule, the sodium and bicarbonate are reabsorbed like a co-transport. So because of this inhibitors, now they are no more getting reabsorbed. So examples are like here acetazolamide inhibitors, it inhibits the calcium carbonic anhydrase. So there is excessive loss of bicarb and also water, so it leads to diuresis and also acidosis. Why acidosis? Because you can see bicarbonate should be reabsorbed, then only everything will be in balance. But here, as the bicarbonate is losing more, of course acidic nature will increase more, so that it will lead to acidosis. Now let us see the mineralocorticoid receptor antagonist. So they mainly decrease the sodium reabsorption from and potassium secretion into collecting tubules. So mainly collecting tubules have the sodium reabsorption capacity in the presence of aldosterone, right? And also potassium secretion into collecting tubule. This is the main function of aldosterone. So here we have some drugs like spironolactone, eplerenone. So actually these are like competing the aldosterone in the collecting ducts. So they decrease the reabsorption of sodium. So like they are like reverse, because our aldosterone leads to increase in sodium and water reabsorption and lead to potassium secretion, but they are like reverse. You can see they are decreasing the reabsorption of sodium and even the secretion of potassium. So sodium remain just in the tubules, so that it will lead to increase in diuresis. So because you can see sodium should be reabsorbed from the tubules into the cell, but now here as they are like acting against the aldosterone, so they will not allow the sodium to enter the cell, so the sodium is just in the tubule, remaining in the tubule, so this will lead to increase in diuresis. So these drugs mainly block the aldosterone. And also they decrease the excretion of potassium, because aldosterone lead to increase in excretion of potassium, but they are like decreasing the excretion of potassium. Spironolactone and others are like potassium sparing diuretics which allow potassium excretion. So we have some drugs like which are sparing, means they are just leaving the potassium, they are only targeting on sodium, so that sometimes even potassium may get excreted even while using these drugs. In some case of drugs, that is called as potassium sparing diuretics. So sodium channel blockers, we have another one, that is sodium channel blockers, which mainly block sodium. So they decrease the sodium reabsorption in the collecting tubules. So we have examples like amyloside, triametrin. So they decrease, what they do is actually they decrease the activity of sodium potassium ATPase and thereby decreasing the secretion of potassium into the tubular fluid. So if the sodium potassium ATPase doesn't work, means potassium will not come into the cell. If potassium is not coming into the cell, of course the secretion of potassium will also further drops. So sodium channel blockers are also potassium sparing diuretics and they decrease the excretion of potassium. So you can see here they are also like we also have some of the sodium channel blockers which are like potassium sparing, means they don't do anything on potassium. Of course if they don't directly act on potassium also, as they are decreasing the activity of sodium potassium ATPase, of course there will be decreased excretion of potassium. So these are also these are also potassium sparing drugs, but they decrease the excretion of potassium. So this is the difference we need to observe here. Before we have said spironolactone is like potassium sparing diuretic, but here this, as it is sparing the potassium, here the potassium excretion is high only. But in the case of this sodium channel blockers, they are also potassium sparing diuretics, but here the excretion of potassium is decreasing because they are disturbing the sodium potassium ATPase. So that is the difference, and you need to mention, you need to observe carefully here between the spironolactone and the sodium channel blockers. Now let us go on to the kidney disease. So how we have most of the kidney disease, how they are, what is their physiology behind them, let us see. So the important cause of death and disability is because of kidney disease, like because you can see kidney have many functions in our body, not only removal of waste, it has metabolism of different proteins, you can see it has different functions, it has production of hormones, endocrine function like erythropoietin. So kidney does many functions and it maintains the body fluids regularity, homeostasis. So if this is not there, what happens, let us see. So severe kidney diseases are divided into two types, like acute kidney injury and also chronic kidney disease. That is like acute kidney failure or chronic kidney failure. So acute kidney failure is abrupt loss of kidney, means suddenly like kidney function is lost, so it may be recovered or sometimes may lead to complete permanent damage. And also we have chronic disease, which is progressive loss, hence the name chronic. Chronic means it will stay for like some few months, like about 3 months or so. So it is like, that's why the name is progressive loss. So acute kidney injury. Acute kidney injury is mainly resulting from decrease in blood flow to the kidney. Of course, if the blood flow drops, even the oxygen that is supplied to the kidney drops. So this is mainly this kind of drop in blood flow to the kidney. This kind of situation is called prerenal. Prerenal means it is mainly acting on the blood vessels which are entering into the kidney. That is the prerenal acute kidney injury. It is mainly due to heart failure, because sometimes if there is heart failure, congestive heart failure, there is decrease in cardiac output. As there is decrease in cardiac output, even the blood pressure drops, even the blood volume drops. So even in some cases like hemorrhage, in hemorrhagic conditions there is loss of blood volume. So that all these conditions, like they're not directly acting on kidney, but they will affect the kidney, because as there is no blood now, the blood which is going to the kidney will be affected. There is low perfusion to the kidney. So this is called as prerenal, means directly there is no problem in the kidney, but because of any blood issues like low blood flow, those all will lead to prerenal AKI. And the next situation is intrarenal AKI. Intrarenal, you can see in the name itself, inside the kidney only there is some problem. That is like abnormality in the kidney itself. So like some blood vessels in the kidney are damaged, or the glomeruli in the kidney are damaged, the tubules are damaged. And next we have postrenal AKI. So in the name you can see the prerenal one is the blood vessels are affected, the intrarenal one is in the kidney only there is some problem. Whereas coming to postrenal AKI, they are like from obstruction of urinary collecting system. So you can see at the last part of collecting, that means the urine is not able to go out from the kidney. In that cases, that is called postrenal AKI. So you can see here from obstruction of urinary collecting system, from calyces to outflow from bladder, right? Most common cause is urinary tract, which is outside the kidney, are like having kidney stones, mainly caused by precipitation of calcium, urate, cystine. So if there are any calcium stones, so that the bladder is not able to empty. So all these conditions, so that it will lead to back pressure in the kidney. So that will of course affect the kidney. So these are the three types of acute kidney diseases. First one is prerenal, next is intrarenal, next one is postrenal. Now let us see what are the physiological effects of acute kidney injury. So mainly retention in blood and extracellular fluid of water. So actually here in this the problem, either it is prerenal, postrenal or intrarenal, the blood and extracellular fluid of water, like there is some damage in the kidney, so it will lead to waste of metabolism and electrolytes. They start accumulating and water and salt overload lead to edema, hypertension, and retention of potassium, hyperkalemia. The value will be, if the hyperkalemia value is above it, it will also be fatal. So because of any kind of acute injury, here hyperkalemia is formed, even some edema is formed, hypertension is formed. So patients of AKI develop metabolic acidosis because there is higher amount of hydrogen ion. So it's lethal, or it may aggravate and finally lead to fatal condition also. So severe AKI may sometimes lead to completely anuria, means if the acute kidney injury is so severe that even the urine stops to come out. So it occurs in patients so that the patient may die within 8 to 14 days unless the kidney function is restored, or artificial kidney is used to get rid of excessive retained water, electrolytes, waste. Of course, we know kidney is the major one to remove all the waste. So of course, if the kidneys are damaged and the waste start accumulating in your body, lead to acidosis, hyperkalemia. So all these conditions. So if you want to get rid of all these conditions, you can do dialysis, by using artificial kidney. We just try to remove the excessive fluid until our kidney again comes to normal. So what is chronic kidney disease? Is actually associated with irreversible loss of nephrons. So sometimes like some parts of nephrons or completely whole nephron is lost. Irreversible means again it can't come. So that is a chronic kidney disease. Chronic kidney disease may be like at least for 3 months along with some progressive loss of nephrons. So if 70 to 75% of nephrons are lost, then it may lead to serious clinical symptoms. So in that case, it may also lead to end stage of kidney disease, where you need to just replace, we need to transplant the kidney. So vicious cycle of cease leading to end stage renal, that is chronic kidney disease. So this chronic kidney disease goes into end stage renal disease, like some patients which are undergoing dialysis or transplantation. So we need to do just that treatment because now there is no chance. So ESRD is nothing but end stage renal disease. So removal of kidney may lead to adaptive changes, like we need the blood flow may increase, the glomerular filtrate rate may increase, urine output also may increase. But over several years, these adaptive changes increase the injury to other nephrons as well. So sometimes as some nephrons are lost, in other nephrons also there will be changes, like the blood flow will increase, because as those nephrons are lost, now they need to compensate those nephrons lost to form the urine. So in other nephrons we can see high pressure of glomerular filtration rate, high pressure of blood flow. So because of all these adaptive changes also, in turn these are also giving more pressure to the other nephrons, so they will also lead to further damage to our kidney. So increase injury to other nephrons as well because of sclerotic lesions. Sclerotic lesions are nothing but like as those tissues are replaced by connective tissue, right? So because of this connective tissue, now there is lot of pressure of work for the other nephrons. So they obliterate the glomerulus and decrease the function of kidney, that terminates in ESRD, that is end stage renal disease. So this may also sometimes obliterate the normal nephron. So because of that, the glomerulus may get damage of a new nephron, so that the function of kidney may be completely terminated. So by decrease in arterial blood pressure and glomerular hydrostatic pressure, mainly by angiotensin converting enzyme inhibitors or angiotensin 2 receptor antagonists. So what we need to do immediately is we need to use the angiotensin 2 receptor antagonist. Now we need to immediately inhibit them, because if angiotensin 2 is activated, it will activate aldosterone. Aldosterone will lead to sodium water reabsorption. It will lead to further increase in blood pressure. So now we need to immediately stop this. Means completely we need to stop the angiotensin converting enzyme inhibitor, so that aldosterone will be not activated, so that the blood pressure will drop, so that diuresis may take place. So now we need to take steps of diuresis, because there is lot of pressure already to the kidney in the case of chronic disease. And the causes may be, the leading cause of this disease is the diabetes mellitus. So in the patients who are already having diabetes mellitus, we can see this disease. So there is increase in blood pressure, or like in hypertensive patients, and also in glomerulonephritis, and also polycystic kidney. So all these diseases, and also obesity. So you can say obesity is a major factor for all this. It's a risk factor for the formation of diabetes mellitus. Also it is a risk factor for the increase in blood pressure, that is hypertension. So if someone are having obesity, they are having higher chances to form the chronic kidney disease. And 90% of diabetes mellitus is formed by obesity, and 65 to 75% of hypertension is also formed by obesity. So obesity, diabetes mellitus, hypertension, glomerulonephritis, polycystic kidney. So all this may be the causes for end stage renal disease, or also nothing but first the chronic kidney disease comes. If it is like going to more severe cases, then it may lead to end stage renal disease. So if a person is in under end stage renal disease, we need to do the treatment just by transplantation of the kidney or else just do dialysis. Now let us see the nephrotic syndrome. So nephrotic syndrome is nothing but excretion of excretion of protein in urine because of increase in glomerular permeability. So actually here in the case of nephrotic syndrome, the problem is normally our glomerular membrane is not permeable to proteins, but here as the glomerular membrane has some defects, so because of this it is also starting allowing the proteins. So because of this it may lead to nephrotic syndrome, that is loss of proteins in urine. So this will lead to increase in plasma pressure in urine and also associated with chronic kidney disease. So sometimes chronic kidney disease also may lead to nephrotic syndrome, or increase in glomerular permeability, loss of protein by chronic glomerulonephritis, or amyloidosis, that is abnormal protein deposition in blood vessel walls and damaged basement membrane of glomeruli. If the basement membrane damaged, then like proteins will be more permeable into the glomerular filtration. And minimal change nephrotic syndrome, like there is a loss of negative charge in the basement membrane by abnormal by antibodies are attacking on it. This may cause severe edema as proteins are lost. So in minimal change, actually what happens is our basement membrane is kept always negative so that the proteins will be repelled and only positive charge or small particles can be allowed. But here this negative charge is lost, so easily the proteins are getting out from the urine. So because of this there is lot of urine with protein, and also as the protein is lost, now you can see the colloid osmotic pressure will be dropped. So this will lead, of course, if the colloid osmotic pressure is dropped, lot of fluids start leaking and also lead to edema in the body. So we'll see the effects of renal failure in body fluids in a part 2.